obstructive sleep apnea in inpatients. With us today is Dr. Fotanakis he's the medical director in our Sleep Disorder Center, and Marcia Hazlitt is here. She is our lead polysomnographer. How did I do on that? Oh, very good. Okay, I've been practicing that a few times. And let's get started. I know we're running a little bit behind, so here we go.
Okay. Oh, gotta turn myself on. 1001, 1002. Can you hear me? Okay. Yeah, a lot of Greek words, I guess. Polysomnography, Hazlitt, and Fotanakis. Nursing appreciation. About 36 years ago, maybe a little bit longer than that, before I got into medical school, I was getting my clinical experience working as a neurodiagnostic tech over at St. Mary's Hospital in Long Beach. And so one of my first patients that I came across, they call us in on call to do these tests and stuff. So I walk in the guy's room, and there's this old guy lying in his bed, and his mouth's open, and he's going... So I thought it was my first case of sleep apnea, and then I called the nurse in to give me a hand because the guy looked like he was going down for the count. And she comes in and she does a great two-finger sweep through the upper airway, pulls out a wad of tobacco about this big, and she yells at him. She starts going, "Where did you get it? Where is it? Where is it?" And she goes through everything, and she pulls out about 3 packs of these things. And so somehow people were sneaking them into him and stuff, and I learned my lesson that day. But anyways, medicine's kind of an interesting thing, and it goes beyond, a lot of technical stuff, and a lot of it is just general knowledge and practical knowledge and stuff, and some of it's just chewing tobacco. Anyways, we're going to talk about sleep-distorted breathing. There's different types of apnea. There's obstructive apnea, which most people know about. Central apnea and complex apnea is a new term that somebody made up and put it in a journal, so I threw it in there as well just in case you come across these terms. But the most common one that we talk about is obstructive apnea, and it's obstructive because there's an airway obstruction going on, but the patient is still trying to breathe, so the airway closes off and there's still respiratory effort. This is the one that's associated with snoring and gasps, and usually the patients are obese, and there's an actual mechanical obstruction going on in the upper airway. Central apnea is much more rare, and people usually think it's something going on in the brain, hence the name central, like central nervous system, but we actually see it more often in things other than stroke. We see it with congestive heart failure, and narcotics probably much more often, and then Marcia does it to a lot of our patients by putting them on CPAP, which is a very common way of inducing central apnea in some patients with very severe obstructive apnea. They convert over to complex, where they have elements of both types of apnea. They have obstructive and their blood gases are all out of whack, and so we open up their throat and start ventilating them, and then everything comes back into balance, but the brain isn't used to being in balance, so they start breathing in a central manner with a periodic breathing. You'll hear about apneas and hypopneas, and so I thought I'd just go over some terminology very quickly. And apnea is another Greek word. It means without breath, so it's an absence of airflow. And hypopnea just means a decrease in airflow. So there's various definitions about how much of a decrease there is, generally about 30%. But physiologically, what it does to us is essentially the same. So an apnea is essentially equivalent to a hypopnea in what it does to the body. So either the apneas or hypopneas can be central or obstructive in nature. And when we're scoring them, when we're counting them on tests, they have to have a certain airflow reduction that lasts greater than 10 seconds, and there's a dip in their oxygen saturation by several percentage points, and it ends in arousal. So when we're counting things up, there's prerequisites and definitions and such, but it doesn't always apply to the patients. So just to kind of get a gander at what this stuff looks like when we do sleep tests, this is airflow up on top in blue. And these two colors here are belts around the chest and abdomen showing respiratory effort. So, and this is oxygen saturation on the bottom. So here we're seeing an absence of airflow, but also an absence of respiratory effort, so that's a central apnea. And over here, this person's still trying to breathe, but the airflow goes down to nil, so even there's a little bit going on there, so we call that a hypopnea as opposed to an apnea. So that's kind of what it looks like on paper. And this is a person having a set of hypopneas where there's still a fair amount of airflow coming through some of the times, but you can see a distinct difference here when they're breathing and they're breathing less. And each one of these is associated with a dip in their oxygen saturation. This is about a 5-minute period here, so you can see he's having them pretty frequently. So when we're talking about how severe apnea is and such, we usually use the apnea-hypopnea index, or the AHI. So you might see that term flung around a little bit. Basically what the AHI is, it's the frequency of respiratory events per hour of sleep. And so the higher the number, the worse the apnea. So it's like miles per hour. This is apnea per hour. And we just count up the number of apneas, the number of hypopneas, and divide by the sleep time to get the number out. So normal is less than 5 per hour, so everybody in the room has a little bit of apnea, and they can still be designated as normal. And mild is 15 to 20, and moderate 20 to 30, and so forth. But the magic number for treatment, when we see them in the lab, is usually at 15, and that's when we see the long-term health risks kick in. And so that's when most people go on some type of treatment, and there's kind of gray zones where they're borderline and maybe they need treatment or not, depending on their clinical history. In terms of severity, we also take into account how deep the oxygen desaturations are with each apnea, and whether or not they might have cardiac arrhythmias associated with the respiratory events. So even though they might have an apnea index with a lower number, if each time they stop breathing their oxygen just drops out, or they start having arrhythmias each time they stop breathing, then you get a little bit more excited about those people. So the AHI, the apnea-hypopnea index, predicts long-term morbidity. So again, like I said, if it's above 15, you see a higher incidence of things like hypertension and heart problems and lung problems and stuff. And then for our purposes, like in an inpatient, if they have really deep desaturations and they are cardiac arrhythmias, it might be a little bit more ominous and put them at risk of some sort of short-term thing happening like sudden death. I'll be throwing up oximetry a few times. The type of oximetry I think you mostly see is, you'll be seeing the numbers going up and down, and you'll be seeing the pulse slowing and, getting more rapid and such on a real-time basis. It's much easier to see what's going on with sleep apnea patients looking at them over an entire night printed out like this. These are 15-minute segments down here, and this is good old military time that I can't read right now. Is that 10 o'clock? 2200, 2300, so forth, going that way. And it continues up here. But what you can see is what happens, this distinguishing characteristic of sleep apnea is not just that the baseline oxygen saturation drops. The baseline would be defined as where these little dips end up here. So they return up to the baseline. And the baseline in this patient is probably about 93–94%. But each time he has an apnea, there'll be a drop and a quick recovery because the apneas last about 20 seconds, 30 seconds or so. And so what you see are repetitive desaturations that occur. And what you see here is a period of dream sleep. Apnea gets worse if you lay on your back or if you start dreaming, and it's at its absolute worst when you're doing both of those simultaneously. So in this patient, you can see that he starts having much more deep desaturations with each respiratory event, and that one there is going down to about 55%. And they're happening so frequently that the baseline is starting to go down. And then right after dream sleep, it pops back up, and he's doing this pattern again. And over here, just to see that he's put on CPAP, and as they turn the pressure up over here, you see these things disappear, so the apnea has gone away, and then he's having a period of dream sleep and starts to have more dream sleep up here as a rebound because he's been deprived of dream sleep because of this stuff. But you can see how good the CPAP works when things get really flat there. So obstructive sleep apnea, The symptoms, you know, when you're seeing patients on the ward and stuff or being admitted and whatever, it's really simple to get a history out of them to see could they have sleep apnea and do you need to worry about them. So snoring is the most obvious symptom. The thing about sleep apnea patients, like a lot of my patients, they're all sleeping when they're having their symptoms. So sometimes, you know, they don't know what's going on. And you have to actually rely on their sleep partner. And then their sleep partner has to be reliable. They have to be awake so that they can see what's going on. But generally, if somebody's got sleep apnea, they're snoring, and they're snoring pretty profoundly. From the person themselves, non-restorative sleep means that they might be sleeping through the night, but when they wake up in the morning, they just don't feel restored. It's not refreshing. So a lot of times people think of sleep disruption as, you know, more like insomnia. You can't sleep when you're in bed, but most apneas patients, you'll ask them, oh, I sleep great at night. I have no problem. I put my head on the pillow, I'm out, and then I sleep all the way through. I might get up a couple of times, go to the bathroom, but I go right back to sleep. That's because they're hypersomnolent. They're too sleepy, so every time they put their head on the pillow, they're out. And but when they wake up in the morning after 8 or 9 hours of sleep, you ask them, you know, are you rested? And a lot of times they say, well, you know, it might take about a half hour, an hour to clear the sleep out of my head. And then in the daytime, excessive daytime somnolence or sleepiness, it's another symptom that the patient may be aware of, or maybe they don't. A lot of times they doze off and they're not aware of it and such, but usually they can give you an idea that they're sleeping more often in the daytime. Most human beings should be able to stay awake throughout their daylight hours, with the exception there is a little siesta period in the afternoon where we have a natural dip in our circadian rhythm and we become sleepy then. And maybe we should be sleeping, but if you have excessive sleepiness on top of that, that becomes a very profound period of sleepiness and sometimes irresistible. So excessive sleepiness in the daytime. And then everybody knows that sleep apnea patients are obese and, you know, they're short little middle-aged men who are 300 pounds. But as we got into examining this condition more and more, we find that there are more patients who are not that type of configuration, so to speak. There's a lot of people who are not that overweight, and there are some people who are not overweight at all. Their facial structure determines their apnea. So you have to be careful not to overlook these people. Just because they're not fat doesn't mean they don't have apnea. So on physical examination, again, just very brief and obvious things are easy to see. You know, of course, obesity is up there on the top, but there is a greater correlation between neck circumference than there is in body weight itself. And so if somebody has men over 17 inches and women over 15.5 inches, and I think for some reason they upped women to 16 inches lately. I don't know why, but when they're above that circumference, neck circumference, then they're at a higher risk of having sleep apnea. If they have an obstructed nasal airway, then they are more likely to mouth breathe when they're asleep, and that causes apnea to get worse. If they might have something obvious like big tonsils, a big uvula, a red uvula, big tongue that's pushed back in the throat, or if they're real cheeky on the inside, that may predispose them to having apnea. And then people with flatter faces, they can, their tongue may be pushed back into their throat more, and so they can be thin people but have pretty bad apnea. Apneic snoring is characteristic. I mean, it's habitual. It means most people who have serious apnea will snore every single night. The snoring is broken by hesitation, gasps, and snorts. The hesitations are the period of apnea when there's no airflow, so there's nothing rattling around the throat tissues to make the noise. The gasp is when the airway opens up again and the air rushes through the throat, and the snorts kind of go along with that. If you can get the history, it's great. If you can't, then you kind of have to work it a little bit. What I found in our patient population is that sleep partners, if you can get a history out of them, the husband or wife who's watching the person with apnea, if they say, hey, I see this guy, he stops breathing, or he is snoring and he's gasping and snorting, odds are that he has sleep apnea. significant enough to treat. We found in our patient population, which will be skewed because people are sending them to us to evaluate, but about 88% of those patients who had a positive history ended up having treatable apnea. So sleep partners are fairly accurate most of the time. There are some apneics who don't have prominent snoring. If they've had upper airway surgery for their snoring, they took out their uvula and their soft palate or part of their soft palate, and so there's nothing to rattle around. If you're not passing a lot of air, you don't snore a lot. So beware of the great big guy with a big thick neck who is very sleepy but says, I don't snore at all, because he's probably not passing any air. He's not breathing when he goes to sleep at night, so there's nothing to rattle. The airway dynamics. If you think about your airway, it goes through your nose, down through the back of your throat, and into your windpipe. And the back of your throat, or your pharynx, is the only part of the airway that's not rigid. The nose is made out of bone and cartilage, and the windpipe is made out of cartilage, but in between the voice box and the back of your nose, it's all that soft tissue you see in the back that moves around when you say ah. And because it's not rigid, it can move around and collapse and obstruct the airway. So people who snore and have apnea, they typically have some type of narrowing in the pharyngeal airway that predisposes them to have this problem. And while they're awake, the pharyngeal muscles can open the airway up so they don't snore or have apnea while they're awake. But when you go to sleep, those muscles relax, and so the airway will relax and narrow, and then that's when they run into trouble. So if you look at this guy who's been sawed in half, you got your nose up here, so this is the nasal airway up to the end of the hard palate. Then you have the soft palate here, the tongue, the back wall of the throat, the epiglottis, and you're getting down into the trachea down in here in the larynx. But the problem area is right here where all this soft tissue is. The soft palate gets sucked down from above, the back wall of the throat gets collapses inward, and the back of the tongue falls back into the throat. So this is where things collapse and people run into problems. So if you put it as a diagram, I drew this myself. Anyways, you got a person here. He has a rigid airway like a pipe, and then you have a non-rigid airway like a balloon, and another rigid airway, which is the windpipe. And so if you straighten it all out, you got a rigid pipe, non-rigid pipe, rigid pipe. So if you put your lips down here and you suck and you try to get air through this thing, what happens is that the negative air pressure will cause a collapse of the non-rigid airway. So that's what's going on in this guy's throat because of the apnea. So again, this is illustrating it sideways. I drew this one too. This one here is it's supposed to illustrate the chest cavity and the lungs, the windpipe, the pharyngeal airway, and the nose. And so to get air into your lungs, you expand your chest cavity, you create a negative pressure there. So because that's a negative pressure that's translated all the way along the open airway, the air will rush in from the outside to fill your lungs. So, but when you put the negative pressure in that non-rigid airway, again, it causes a collapse. And so that's where the obstruction occurs. Then if you have a nose that's plugged up, you have to suck harder down here and create a greater vacuum there that sucks it closed even worse. So that's how the nose contributes to things. So the apnea cycle is the sleep allows the airway relaxation. As you inhale, it increases the airway collapse and produces snoring because there's still air rushing through that area of the throat that's made of soft tissue and everything's fluttering around. Then when it closes off completely, total airway obstruction, the airflow stops, and so the snoring stops, so that's when the hesitation occurs. And then at the end of it, you wake up, the pharyngeal muscles contract, the airway opens, and that's when you hear the snort. And then you fall right back asleep and you do the whole thing over again. So apnea patients do this over and over. So again, sleep, snoring, apnea, arousal, sleep. The apnea cycle. It's SAS. I made that up too. Okay, what happens to inpatients when you bring them in? What kind of things do you guys do to them to make my apnea patients worse? I always warn my apnea patients when I get new ones, especially ones that have moderate to severe apnea, look at guys, if you ever go in the hospital, Take your machine with you, take your mask with you. You know, tell everybody that you got sleep apnea just in case, because bad things can happen to you. So what kind of stuff happens to you in the hospital? Hospital beds. Very often patients end up sleeping on their back, and you might prop them up a little bit and stuff in a hospital bed. But again, being on your back is a bad position for most people with apnea. It's just a matter of gravity. If you're obstructed and your mouth is open, your tongue is loose, it'll fall backwards into your throat more, and so you'll obstruct your throat more and you'll have worse apnea. If you turn them on their side, it has a greater propensity to fall forward and open the airway, so they have less apnea. Some people, it's a profound difference. They go from having no apnea or snoring to having severe apnea. Some people who are just, you know, big bull necks and just a small airway, there won't be that much difference. But there usually is some difference in most patients. So a lot of times patients end up supine in their hospital bed, and then very often they get sedation from one reason or another. Either they can't sleep and they ask for that Ambien, that's PRN, or you know, they're sedated from anesthesia or something else, and so that puts them down more. So what rescues you when you have an apnea? You have to wake up to breathe. What does sedatives do? It keeps you from waking up, so the apnea lasts longer. Narcotics is a double whammy. Narcotics not only sedate, but they also depress respiration. So again, they make you breathe slower. And if you ever see somebody with, you know, like a narcotic overdose, if you titrate them a little bit, they'll go from breathing regular to having periodic breathing, where they breathe deep and then they stop and breathe deep, and then pretty soon it just goes flat. So you do that to an apneic, it just makes it that much worse. I've been I was called on as an expert witness in cases a couple times in a hospital that involved patients who usually they come out of OR, nobody got the history that they're apneic, and the patient didn't volunteer it, and then they have anesthesia on board post-op, and then they start getting a little bit of morphine here and there, and somebody shoves them off into some corner someplace and then checks on them, and, you know, a half hour later, and by that time they're gone. And so it can happen, so you have to be careful with these people. And it's easy to recognize them, you know, if they're coming in from OR and they're overweight, and you see them having respiratory difficulties, namely they're snoring and gasping and those type of things, then you might want to keep a closer eye on them. Can I get a witness? Not everybody has a sleep partner at home, and very often the inpatient staff, you people, are the people who are seeing them sleep. You know, you are the sleep partner, so that you can see them having their apnea, and we actually get a fair number of patients who are referred over after their inpatient stay, after they've had their colonoscopy, or what other nice things can doctors do to people, that where they get the, you know, conscious sedation, and so during the conscious sedation they have you know, apnea, and so they get sent over to us for further evaluation. So it's also helpful in the after hospital care type of thing. There's short-term morbidity or sleep morbidities associated with sleep apnea, and largely this comes from the fragmentation, the fact that they go through that apnea cycle and they wake themselves up over and over again. And so with each of those little arousals, the person, it's kind of like somebody nudging them over and over through the night. If somebody has an apnea index of 60, that means that they stop breathing and they wake themselves up to breathe every minute that they're asleep. So 60 times 8 hours. How much is that, everybody? That's right. Anyways, it's a lot. You know, it could be 500 times, 800 times in some people. We have some people with an apnea index of 100, 120, 130. So some people have very severe apnea, a lot of sleep disruption, and they're very often mistaken as being narcoleptic. So sleep fragmentation is the big culprit when it comes to the sleep morbidities. And so the patients complain of the non-restorative sleep. They sleep a normal amount of time, but they're never rested, and the excessive daytime sleepiness. Now here's the stuff that we have to worry about in inpatients. Not all of it. Some of it is long-term things, you know, like there's a higher risk of hypertension, pulmonary hypertension, and sleep apnea, and all these other things. But I put asterisks around things that you might come across an inpatient. If somebody has severe apnea and they're having significant desaturations and stuff, they can have cardiac arrhythmias associated with each one of those desaturations. Sometimes we have people come in and you know, at the end of their apnea, they start flipping PVCs and such, and so they're kind of scary to watch them. And most apneics will have tachycardia, bradycardia that's associated with the event. When they are obstructed, their heart rate goes down, 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 and as soon as it breaks, it flips up and they start having tachycardia. And sometimes that's very profound, and you'll see that in younger people, a much bigger difference than in older people. I don't know what happens to us when we get old. Yes, I do, but I'm not saying. Anyways, cardiomyopathy, you know, congestive heart failure. These people, I don't know, they come in every other month in the emergency room, and then they eventually send them to us when they're discharged. But you'll see somebody like a 25-year-old who's 400 pounds, and they're in florid congestive heart failure, and their CO2s are up in the air someplace, and it's all due to their sleep apnea, their severe sleep apnea that hasn't been treated. And along with getting the fluids off of them and doing all this other stuff like you might with a regular congestive heart failure patient, you put them on some type of CPAP or BiPAP, because that's actually the main thing. You open up their airway, let them breathe again, and they start diuresing and stuff, and it prevents it from happening again. There is a higher incidence of stroke with sleep apnea, but there's a fair amount of stuff nowadays also in somebody who comes in and has a stroke. The recuperation and the recovery is better in people who had a stroke if they have sleep apnea. You treat their apnea. They're not exactly sure. There's theories about, you know, maybe we're getting more oxygen up to the brain and blah, blah, blah. But in any case, it's good to know that if you see somebody, you know, if you have a stroke patient and you see them having snoring and hesitations and gasps and stuff, it might be worthwhile to go ahead and treat them and notify people to get them treated so maybe they recuperate better. Sudden death is always a complication you don't want to see in one of your patients. And that, again, is it's probably related to cardiac arrhythmias. The most common time for sudden death is in the early morning hours, like 4 or 5 o'clock, which is coincidentally when most of our REM sleep is concentrated, which is coincidentally when sleep apnea is at its worst. So REM sleep is not a great state to be in. Your heart is like varying. This is just normal. The heart varies in rate and rhythm and such. And so arrhythmias can come out more often anyways, and the breathing fluctuates and all that amplifies the apnea, so the apnea gets worse. And so it's very easy for these patients to flip into some type of toxic arrhythmia, and you get this as a result. So these are things that, you know, reasons to kind of be on the alert for patients who might have significant sleep apnea in the hospital. In the sleep lab, we use polysomnography to diagnose them. You know, we look at their EEG, eye movements, chin EMG, leg EMG, audio recordings, respiratory flows and oximetries and stuff, and we put it all together and it looks like that. And this is the EEG on top. That's how we tell whether or not they're awake or asleep. And this patient's awake. Why? Because it says W here. No, this is an alpha rhythm up on top. And then these are the eye movement channels that helps us know whether they're awake or if they're in REM sleep. And their EKG, of course. And these two green ones are electrodes on their legs to pick up leg movements in case they have periodic limb movements. Then we have a chin EMG and a snore, a microphone. So you can see this guy snoring right here. And this is the airflow again, and the two respiratory effort belts and oxygen levels. So each one of these is 5 seconds, so we're looking at about 30-second period there. Here's somebody who's having a lot of apnea, and we kind of squished it all together in a 5-minute segment, so you can't see the rhythms as well as you did in the other one, but you can see the apneas better, because this guy's apneas are lasting about 30 seconds apiece. So he's not passing any air for 30 seconds, then he takes 3 breaths, and he's not passing any air, 3 breaths. And each time his airway opens, you see the gasp here. And also in the leg EMG, you can see that he's actually jerking his whole body as he goes like that each time. And up here, there's a burst of activity in his EEG because those are the arousals. So the arousals only last, about 5 seconds, 3 seconds sometime. The patient doesn't know he's having all these arousals. He more or less is sleeping through them, but they do add up and they do cause sleep fragmentation and they result in the problems with sleep. So here's another oximeter. Again, another guy who's having pretty profound desaturations with each one of his events. And this one's fun because it drops off the bottom of our oximeter reading here during a period of REM sleep. And then you put him on CPAP and boop, it goes up like that. So you open the airway up. What will happen, what you guys see when you're looking at your oximeters on the nursing stations and stuff, I guess, unless you get printouts like this, anybody? No? Yeah. You'll be seeing the thing, all of a sudden it drops out, run over to see what's going on with the patient. By the time you get there, his apnea is over with and pops back up, so you go back over, and then it's down again. So that's what's happening with this stuff. So it's hard to see it in real time, but when you see it all concentrated like that, it's very obvious of what's going on. There's dips each time he has an apnea, and the dips are very short-lived, but they get profound. Now, if any of you who are not smokers hold your breath right now for a full minute, you might be able to move your oxygen saturation from 98% down to 96% if you hold your breath for a full minute. What you're seeing here is probably within about 20 seconds, this person is dropping his oxygen level from 95% to below 50%, and then it pops back up again. And the reason for that is not just oxygenation, it's shunting of blood. Essentially what happens is during the apnea, you have venous blood bypassing the lungs, which are now collapsed, and going directly over the arterial side. So that's how you get such a profound drop in oxygen level in such a short time. And so there's more going on than oxygen here. So a lot of times people will be seeing, oh gosh, their oxygen levels are really going low and stuff. Let's put oxygen on them. Nothing happens. Their airway is obstructed. It's caught on my pant leg. Their airway is obstructed, and so you're not getting the oxygen in, and a lot of this desaturation is actually from shunting, and so the cure is to open the airway. This guy doesn't even have oxygen, supplemental oxygen. This is just CPAP alone. So a new thing that we have in our lab is portable monitoring, being able to diagnose people by putting a little device on them and sending them home with it. It only looks at 4 parts of the polysomnogram. And so for inpatient diagnosis, this may be necessary only if an insurance company needs you to do it. But basically, you can look at a patient and also look at what's going on with the oximeter and say, hey, this guy's got apnea, obstructive apnea, because he's snoring and snorting and stuff, and I see him stop breathing. So you can make the diagnosis without a device. What we've run into is sometimes a patient gets diagnosed in the hospital, they get a CPAP or BiPAP put on them, and then we go to send them home, and the insurance company or Medi-Cal or Medicare or whoever won't pay for the device at home because they haven't been diagnosed with a device. So there are occasions that we may be putting something like a portable monitor on them just to get some data for one night to appease the insurance companies for payment. But if they don't require that and you guys made the diagnosis, it's much better to get the patient on the device at home and have them use it for a little bit and then come into the sleep lab afterwards to have a regular test done so that we can make sure everything's going okay. And by that time, maybe their heart failure cleared up and we can get a better reading of what's going on. So the portable devices have the nasal airflow, the respiratory effort, heart rate, and oximetry, and they're all monitored simultaneously. So it looks like this. This is the actual monitor. This is the oximeter that goes on the finger. These are like the oxygen cannulas, except they measure nasal pressure. And then this is an elastic band that goes around the chest So you kind of look like this. All this stuff is clipped to him there. There's his oximeter, and there's there. Wife is very happy. Ha. And the average sleep apnea patient looks like this model here. Ha. So, okay. Anyways, in terms of treatments, you know, there's weight reduction, positional therapy, CPAP or BiPAP, upper airway surgery, dental appliances, and keep away from sedating substances at bedtime. So the stuff that you know, we can look at in terms of inpatients that, you know, previously undiagnosed sleep apnea patient gets admitted for whatever reason, and they're getting into trouble. You know, their apnea is so bad that you know, their oxygen levels are going all to heck, and you know, everybody's worried about them. So, you know, what can we do for them? Well, you can't put them on an instant diet to lose enough weight. So that's something that's kind of more of an aftercare thing that maybe gets them hooked up into something. How successful is dieting, everybody? I can tell you how successful it is in me. Not. But anyways, so weight reduction is very difficult for most people, but it's worthwhile still trying and setting somebody up with it after discharge. So this is a question that they used to teach us in medical school to ask during our mental status examination for psych patients. Isn't that a great proverb? It comes from, what does it mean? Anybody want to volunteer? I'll tell you where you're schizophrenic or not from this. I'm just kidding. The tongue is the enemy of the throat. So most people who are not schizophrenic would say, well, that means if you talk too much, you're going to cut your own throat. Schizophrenics usually do this very literally, and they think that you're going to cut their throat for them. But in any case, getting back to positional therapy, the tongue is the culprit, as we said before, and gravity. So gravity will move the tongue back into the throat, and they'll have more problems. So it's very simple, or maybe very simple, if you see a patient who's having problems and they're supine in their bed and stuff, you know, get them off to their side and see what happens. You don't have to turn them all the way over, but turn them, you know, enough over and prop some pillows behind them and see if that opens their airway, and maybe that'll do the trick. So positional therapy in the hospital, might be a viable way of treating things. Also, large abdomens can produce respiratory restriction in shunting and result in hypoxia. So sometimes you get some guys who are so big that their stomachs are pushing up on their diaphragm and they can't fully expand their chest cavity, and so they have persistent hypoxemia. And so no matter how much they're ventilated, it's not getting down there. And so sometimes you just have to decompress them by getting them on their side or getting them, raising the head of the bed, whatever it takes, to see if that might have effect on improving the oxygenation. Again, this is something that's related to shunting as opposed to not getting the oxygen through. So giving these people supplemental oxygen may not have a whole lot of effect. You may get a better effect by moving around. One of my friends who's in sleep had a patient who was, he's this great big Samoan guy who was like 400 pounds. And he had him, while he was awake, sitting up in one of those little portable oximeter things on his fingers, and he was normal, and then he laid him down, and he was still awake. But just the process of laying him flat, he just desaturated 30 points right in the office. So sometimes it's a really big thing in some patients. So it's easy enough to do, and it's worthwhile trying if you see it. Avoid sedating substances. That's kind of hard to do in an inpatient setting, you know. Somebody's coming out of surgery, or they're getting pain medications or sleepers and that sort of thing. But at least use caution if sedating substances are being used and the person has symptoms of apnea, then keep an eye on them, or closer eye on them, or maybe stick an oximeter on them with an alarm. Surgical treatments, you know, a lot of the surgical treatments that are done outpatient are on the soft palate, cutting it or reducing the size of the tongue or doing other things. In the olden days, tracheostomy used to be the treatment of choice before they had CPAP. And it worked most of the time because it bypassed the problem area. Up here, the obstruction was going on, so you open up the airway down here, and their apnea would go completely away. So in an emergency situation, this can be something that you call one of the ENT surgeons over to do, but they'll have is it a cow or an ostrich. They'll have a cow because even though this is curative and stuff, you have a patient, these patients, you know, if they're having really serious apnea, they'll have big bull necks and stuff. And more than once I've been told, hey, you know, doing a tracheostomy on this person will probably be as dangerous as not leaving them untreated, because just doing the procedure and dissecting down there enough. Yes? Am I run? Okay, we run out of time. And you were having so much fun, too. Okay. Beg your pardon? In summary, you know the symptoms, and you know what to look for now, and you know some of the dynamics of what happens here. And one of the treatments that we have available is the CPAP device, and I'm sure you've all seen that. And a lot of times it's put on as a BiPAP on the inpatients, and they just kind of ballpark the pressure. And so we now have ways of determining the pressure with an auto-titrating machine that we're going to explore, maybe using it on some inpatients. You call Marcia, she'll come running over there. And, but it might be helpful, but at least after the discharge, if these patients can be sent over to the sleep lab so we can fine-tune their treatment. But essentially what CPAP does, it's a pneumatic splint that inflates the upper airway, the part that was collapsing, and it keeps the airway open by blowing it up like a balloon. And then the patient can go back to breathing, and it completely reverses all the short and long-term complications. Okay, good enough?
What do you think of those dental?
The dental appliances? More oximetries. I used to have a picture of it. That's the CPAP machines, and I have one up here in case somebody wants to be mass. I think I might have taken the dental appliance out. Dental appliances work about 50% of the time, and they're kind of an individual thing. They essentially work by jutting your jaw forward and pulling your tongue away from the back of the throat. But the limiting factor is your jaw joint. You're pulling against that, so it's a matter of do you open the throat up before the jaw starts hurting. So you have to see how it works in an individual patient to see if it's viable or not. Okay. All right. Thank you very much.